So today we're going to talk about chronic DVTs and other uh, ways of treating vein problems. Just to wrap everything up, it's going to be a short video just to cover all these issues that we really haven't talked about much. So chronic DVT is different from an acute DVT. Chronic, as the name implies, it implies an older clot. So sometimes we'll do an ultrasound for an unrelated reason, like for example swelling, and we'll see what's called a chronic DVT or chronic inflammation. That suggests that there's been a previous clot before. The vein looks different on ultrasound. It looks thickened. Sometimes there's scarring inside the vein. And so that's a distinct entity from acute DVT. And acute DVT is something that needs to be treated with blood thinning medicine, but chronic DVT does not, because it's old. It's not at risk for breaking off and going towards the heart and lungs like an acute DVT is. So that needs to be treated. Acute DVT needs to be treated. Chronic DVT does not. And I wouldn't say it's a common finding, but it's somewhat surprising. Sometimes we'll see these things show up on ultrasound, and we'll make a note of it. What does that mean to you in the long run? Well, if you've ever had a blood clot or a DVT in the past, you're always at risk for getting another one. Now, it's a slightly incremental risk, but you're always at risk for getting another one. And so you just want to make note of these kind of things and kind of caution people. Look, if you're going to go through what I tell people who've had an acute DVT, if you're going to go through surgery years from now, you need to let that surgeon know that you've had a DVT. They'll treat you differently. They'll do prophylaxis for DVT differently for you. Or, if you're going to go through laparoscopic surgery or orthopedic surgery, spine surgery, something like that, even vascular surgery, you're at increased risk for having another DVT if you've had one in the past. So chronic DVT in and of itself really doesn't need any treatment in terms of blood thinning at all. So that kind of wraps up DVTs. The other thing I wanted to kind of briefly discuss is foam sclerotherapy. We didn't talk about that when we talked about sclerotherapy. So foam sclerotherapy, as the name implies, uses foam. Usually it's a sclerosing solution, which is the material, the liquid that scars the vein when you inject it. We sometimes mix it with carbon dioxide into a foam, and what that does is it covers surface area better, especially for bigger veins. Essentially, you just inject it into the vein. Sometimes we'll do an ultrasound guidance, and what it does is scars the vein up, just like regular sclerotherapy does, and shuts that system down. So we'll use it in certain situations like perforator veins, the connection between the deep system and the skin level. We'll treat some of those with foam sclerotherapy, or reticular veins and other kind of veins that are bothersome. We'll treat those foam sclerotherapy. What that sclerotherapy does is it just irritates the vein, just like conventional sclerotherapy, shuts the vein down, and so there's no flow into it. It sets up sometimes a phlebitis or kind of an inflammatory response that can be a little bit uncomfortable, but time usually takes care of that problem. So that kind of concludes the vein work. Again, feel free to ask questions. I'm going to next go on to peripheral vascular disease, and I really want to spend some time on that because I think that's one of the arenas where there's way too much procedure work done for issues that probably don't need intervention, and particularly for patients who have what's called claudication, difficulty walking distances because of circulation problems. This is a real trend to doing procedures that are maybe not necessary, and we need to discuss this in depth so that you have an idea of what you're getting into when it's recommended to you that you have some kind of intervention performed for your peripheral vascular disease.